Fair enough.
We are now live.
Good morning. Sorry for the slightly delayed start. Good morning and welcome to this meeting of the Health and Wellbeing Board. I am Dr. Julian Povey. I'm the co-chairman of the Health and Wellbeing Board and will be chairing the meeting today in the absence of Councillor Lee Chapman. I'm obliged to inform you that this meeting is being live streamed and recorded. Members of the public will be able to hear the audio of the meeting and view the papers shown on the screen. I will now explain that this meeting is being held using remote technology, and should any committee members experience technical difficulties during the meeting, they should immediately contact the designated IT officer on the number that they've already been supplied with. Everyone is requested to mute their microphones unless advised to speak. Please only use the chat function to indicate the desire to speak. Do not use it for anything else, so that it is clear who is asking to speak and the debate has to be heard by those listening to the audio feed. As the chair, I will interpret the council's existing standing orders in the light of the requirements of remote participation, with advice from the monitoring officer prior to making a ruling. At the start of the meeting, I will ask members to confirm their presence and any disclosable pecuniary interest they have in any of the items on the agenda. I will ask that everyone speaks during the meeting, including members of the committee and officers, that everyone who speaks during the meeting, including members of the committee and officers, to introduce themselves each time before they speak. This is so those who are listening know who is speaking. We'll now do the roll call and the disclosable pecuniary interests. Members are reminded to disclose any pecuniary interest in any matters to be discussed, which is not included in the register interests, and leave the meeting prior to the matter being discussed. I'm going to read out each member's name and I'll ask them to confirm their presence and confirm if any interests. I'll remind you to unmute before speaking, but then obviously remute after speaking. So the list of members for the roll call are voting members: Councillor Dean Carroll, Cabinet Portfolio Holder for Adult Social Care, Housing and Climate Change.
Present, Chair, and no pecuniary interests.
Thank you. Lynn Crawley, Chief Officer of Health Watch. I'm going to unmute and then to speak. Perhaps assume that Lynn, I'll just look in the participants to see if Lynn's here. Just flick back. Doesn't look like Lynn Crawley's here, so we'll continue without Lynn at the moment. David Evans, the Accountable Officer of Shropshire CCG.
Present and no pecuniary interests.
Thank you. Jackie Jeffrey, the Chief Executive of Citizens Advice Service.
Hi, yes, I'm here, and I think the only pecuniary interest I have was under the Better Care Fund, where I am a commissioned service for advice, advocacy and welfare benefits service under the prevention theme, but otherwise none.
I think as we're not making, I've had Val's advice on this, but I think that's going to be fine for you to be during the paper. There's no decisions, is the Val? What would you suggest?
The BCF, that the board is asked to agree the report.
So what would
it's Penny Basin. May I come in, Chair?
Yes, please, Penny.
Yeah. So no, this the planning for the Better Care Fund and the schemes underneath, particularly related to prevention, are not being asked. There's no request for approval for that at this stage.
Yes, that's fine. So Jackie can stay and take part in that discussion. Thank you.
Thank you.
Rachel Robinson, Director of Public Health, Shropshire Council.
Present, Chair, and no pecuniary interests.
Thank you. We then have some non-voting members. Louise Barnett, the Chief Executive of the Shrewsbury and Telford Hospital Trust. Okay, and I'll just quickly check the participants, unless there's a deputy for... no, so we'll assume that Louise is not here, although a representative may arrive. Nikki Jacks, from the Chief Officer of the Shropshire Partners in Care. Again, I've not seen Nikki in the list of attendees, so we'll assume she's not here at the moment. Then Laura Fisher, Housing Services Manager, Shropshire Council.
Yep, in attendance and no pecuniary interests.
Thank you very much. I shall now turn to the items on the agenda. The apologies that we've have been received from Lee Chapman, Karen Bradshaw, Andy Begley, Julie Davis, Megan Nurse, Mark Brandreth, David Stout and Ed Potter. The item 2, this disclosable pecuniary interest, that's already been dealt with during the initial roll call. So we move on to item 3, which is the minutes, and this is to confirm the minutes of the meeting held on the 9th of July 2020. Everyone's had the minutes and read them. Unless there's any comments or corrections, I move that the minutes of the Health and Wellbeing Board held on the 9th of July 2020 as circulated with the agenda papers be signed as a correct record. Could I have a seconder, please? Is there anyone who's
I'm happy to second, Julian.
Thank you, Dave. Thank you. I will now accept these minutes as a true record unless anyone else indicates differently. Item 4 is public question time. We have received a public question from Diane Peacock, to which I'll read out the questions and the response. It's quite a long, detailed question and required a detailed response. So I will I'll read that out, but it may take a few minutes to get through it. Let's have a drink first. So this letter is from a public question from D. Peacock, the impact of COVID-19 on care home residents. It is received on the 7th of the 9th, 20. It is widely documented in Shropshire Council papers and in adult services correspondence with the Right Honourable Helen Whiteley, Minister of State, that a system-wide multi-agency approach working with SDP partners to support care homes was operationally locally by April 2020. Data from commissioners and providers collected by various national agencies, when combined with local intelligence, would have enabled the pattern of COVID-19 cases from March to June 2020 to be analysed at a granular level. We know that the COVID-19 can be seeded into care homes in various ways, and risks may vary depending on specific demographics, localities, types of care home and support agencies. It is in the public interest that it is a shared understanding among agencies about the factors that influence local patterns of infection in the early months of COVID-19. In the event of further community upsurges and in terms of public confidence, it is vital that what has been collectively learned from the local evidence base is used to minimise risks to care home residents. Open, evaluative responses to the questions below should be possible without breaching data protection, data sharing protocols or common understandings. The first question of 7, I think, is which group or individuals within this local system-wide multi-agency partnership is responsible for the collation, synthesis and analysis of quantitative and qualitative data relating to the impact of COVID-19 on care home residents in Shropshire 2020. The answer from the council and from the chairs are: we are and will continue to work closely with system partners, including Public Health England, NHS colleagues and Shropshire Partners in Care, to monitor and support our care homes. As a multi-agency approach, there is no specific team or individual within one organisation who is responsible for the collation and analysis of data. The ongoing analysis of a range of data is a vital part of our system-wide structures to plan, action and respond to issues with care homes as they arise. This gives us a good level of confidence in our system response, which consists of Gold Command, Silver Command, Shropshire Telford and Wrekin Care Sector Task and Finish Group, Shropshire Care Home Support Team, which involves the IPC, Public Health and Adult Social Care Welfare Support Calls, Shropshire Care Home Risk Management Team and Risk Management Process, daily care home review meetings, the Care Home Advanced Scheme Enhanced Service, COVID Council-wide Business Continuity Team, the Adult Social Care COVID Response Team, the CCG, primary care, locality team, and the detailed answer does just list the dates, the timings of those meetings. Shropshire Council Adult Services instigated practical support for care homes and domiciliary care providers in response to the COVID-19 crisis at the beginning of March 2020. We have continued to engage with all providers on a regular basis and to manage emerging risk immediately and effectively. We have a care home risk management process for all providers in Shropshire, and through constant monitoring, the analysis of information from a range of sources, we have a robust and thorough understanding of risk to our markets, low bed occupancy levels, loss of income, and increasing costs associated across the sector due to staffing and PPE and the measures required to support and mitigate risk. Now move on to the second question, which is, on the basis of widely available data, was there any correlation between staff sickness, agency cover and COVID-19 cases in local care homes in the early months of the pandemic? If yes, what was the degree of correlation and what specific mitigations are now in place locally to minimise the risk of further cases in care homes? The board's answer is, in the early days of the pandemic, this information was not widely available, so we are unable to suggest any correlation between staff sickness, agency cover and COVID-19 cases in care homes. The following measures, however, were implemented from the outset to minimise the transmission and outbreak risk. In order to minimise the risk of transmission and prevent outbreaks, Shropshire Council's Adult Services implemented practical support for care homes in response to the COVID-19 crisis at the beginning of March. The formation of the Care Home Welfare Support Team, made up of members of staff from commissioning, contracts and public health, offered support to care homes and weekly welfare calls. The main aim of the calls was to make a general check on the home's welfare, to give them the opportunity to ask questions, share and send information, and enable us to understand their individual response to COVID-19, including the management and isolation of staff with symptoms and staff cover arrangements supported closely by the Infection Prevention Control Team in the CCG, who also answered care homes concerns and individual phone calls. Homes are signposted to guidance where available and given guidance and reassurance where needed. Working in partnership with Telford and Wrekin and Shropshire Partners in Care, the local voice for the independent adult social care sector, we developed a set of frequently asked questions as a means of communicating widely with the sector, updated daily at first, to augment the individualised support homes received in welfare calls. The FAQ provided a source for general, national and local information, including key messages about management of symptomatic staff. In May 2020, the government announced grant funding to support care homes, the Adult Social Care Infection Control Fund, worth £600 million nationally. The primary purpose of this fund is to support adult social care providers to reduce the rate of COVID-19 transmission in and between care homes and support wider workforce resilience. The aim was to ensure that care homes have the financial support they need to implement unprecedented changes to the way they operate, including the management of staff. Given the evidence of prevalence of asymptomatic transmission, Public Health England strongly recommended that care homes do all they can to restrict staff movement, use of different agency workers, etc., in their home wherever feasible. Interim reports from care homes on their intended use of the Infection Control Fund suggest that over 50 of 120 care homes have used some of their grant allocation towards actions which minimise the movement of staff within their home now and in the future. Other homes do not use agency staff, and a very small proportion of homes indicated that they were confident in their ability to minimise the movement of staff. These homes were contacted by the Welfare Support Team and offered additional guidance and support in this area, including the use offer of redeployment of staff from across the system as required to further reduce the risk. I'll move on to question 3. On the basis of widely available data, was there any correlation between hospital discharges into local care homes and subsequent patterns of COVID-19 cases in local care homes between March and mid-May? If yes, what was the degree of correlation and how did this inform multi-agency planning to minimise future risks? ONS data showed the number of care homes reporting a suspected or confirmed outbreak of COVID-19 to Public Health England, together with the cumulative proportion of all care homes that have reported an outbreak, 2 or more suspected cases, are including each week from 2nd of March 2020 to the 13th of July 2020, shows that 43 out of our 120 care homes have reported an outbreak, which is 36%. These, however, do not have a correlation to hospital discharge, as we do not have the evidence to suggest this was where the outbreak started. During April 2020, government escalated the COVID risk across the UK to 4. This means that infection was being generally transmitted in the community. To minimise risk of transmission and break outbreaks in Shropshire care homes following a hospital discharge, Shropshire Council issued a tender on the 31st of March 2020. This went to all providers offering the opportunity for them to submit an expression of interest to provide recovery beds in their care homes for patients who are medically optimised and ready to be discharged from hospital who could or would be possible COVID patients. This was clearly laid out in the tender. The contracts were commissioned in April and remain in place. Operational processes were agreed with clear and robust guidance with a cohesive multi-agency approach to discharge, open lines of communication for all parties, and key contacts from both the provider and hospital social work care team shared. Initial reports from feedback from the care homes managers who secured the contracts advised transmission of COVID-19 in the one group of care homes that have received residents who have a COVID positive result is low. Additionally, 2 care homes that initially had outbreaks before they went live with the recovery beds contract have not seen further outbreaks following residents being placed from hospital, further suggesting there is no correlation between hospital discharge of COVID positive placements and COVID-19 outbreaks. The National Capacity Tracker asked care homes to report on their experience of people being discharged from hospital into their care home. This self-reporting tool offers a good insight and indication of the perception of care homes, but relies on regular updating by care homes to remain current. Information taken from the tracker on the 8th of September shows that 98 out of 119 care homes were confident that the people they had admitted to their care home from hospital had been tested and the results shared with the home on discharge. 11 homes reported that the tests had not been completed on discharge. However, it has been recognised that the initial question has caused some confusion. It was worded, have all residents discharged your care home from hospital been tested for COVID-19 and do you have the results? We appreciate that several homes have no experience of discharging the pandemic and were left wondering to respond positive or negative to something that was not relevant to them. We can therefore assume that homes who hadn't had any discharge answered no simply because they couldn't answer yes. This question has now been amended, and to ensure all of our providers are confident with the hospital discharge process, we'll speak directly to those homes who said no or who didn't respond and ask them to review their answer and ensure that they were confident in the process to mitigate the risk of an outbreak following a discharge from hospital. We are satisfied at Shropshire that we have a robust local discharge procedure in place that requires all patients to be tested before being discharged into a care home. Additionally, along with our colleagues in public health, we are in regular contact with every provider to offer support and answer queries, amongst other things, around hospital discharge and support with national guidance, particularly around admission into care homes. Question 4. What assurance can the board provide that supplies of PPE to care homes, problematic until mid-May according to local care homes, can be sustained in the event of a community outbreak? Our answer is, we acknowledge and appreciate the difficulties our care providers had sourcing and purchasing PPE. The government's response to the challenges with accessing PPE supplies was to provide each local authority with supplies through the Local Resilience Forum, and as soon as Shropshire Council were made aware of this, we set up and launched on the 17th of April an emergency PPI supply process for Shropshire, Telford and Wrekin, which continues to be available. This has also included Shropshire Council's own stocks being provided where the Local Resilience Forum stocks were not enough to support the market. Our engagement with providers again highlighted that they were incurring significant additional costs in relation to the purchasing of PPE, agency staff, funding for staff who were unable to work and other financial challenges. The decision was made to provide funding as a one-off payment as there was clear evidence of an immediate need to support cash flow. In the week commencing 13th of April, all county care homes with council contract with received a one-off payment representative of an additional 10% of their contract value as at the 31st of March 20 for 12 weeks. This included joint contracts with the CCG. We have worked with Shropshire Partners in Care to ensure the information about effective supply chains is available through their website, and we've been working with colleagues in trading standards to make sure the care sector have information about fair pricing for PPE. On the 7th of July, the Department of Health and Social Care launched an emergency PPE portal, initially for care homes with under 24 beds, GPs and domiciliary care providers. This allowed the Shropshire, Telford and Wrekin emergency supply to continue supplying larger care homes and the wider community. The Department of Health and Social Care offer has since been rolled out to larger care homes and is promoted through the welfare calls and through weekly comms with Shropshire Partners in Care and the contracts team. The implementation of the Department of Health and Social Care portal ensures the Shropshire, Telford and Wrekin emergency supply has enough supplies to support the wider community, such as those people in receipt of direct payments who are not eligible to use the portal to access PPE, and supports in reducing the risk of a community outbreak. Regular communication with care providers. Sorry, my computer, although it's plugged in, just says my battery is running low, but it is definitely plugged in. So I'll start that paragraph again. Regular communication with care providers ascertains any concerns and difficulties with sourcing PPE. Additionally, homes reporting issues on the National Capacity Tracker are highlighted and called to support and signpost them to the emergency supplies promptly, whilst understanding why they are struggling to source. Through a system-wide approach of support from regular welfare calls, meetings with the groups highlighted in Q1 and information from the National Capacity Tracker, we can highlight risks, concerns and issues that our providers accessing and sourcing PPE and escalate promptly to mitigate the risk. Question 5. Local agencies appear to have worked hard to mitigate ongoing national problems with swab testing in care homes. However, until all staff members in care homes are offered a swab test every 7 days, what reassurance can you give the public about the safety of care home residents given recent community and care home outbreaks in Shropshire and elsewhere? And the board's answer is currently government guidance and systems are in place in order that care homes can order and undertake staff testing in all care homes every 7 days. We are working with care homes as local businesses in order to support them to be able to deliver testing. Results are reported directly to the care homes. Results are also being reported to Public Health England and via Public Health England to our local public health team. In this way, any outbreaks are notified. We are increasingly finding that the numbers of staff who are reporting positive are asymptomatic and residents are asymptomatic. We are working with any care home that does have an outbreak to ensure that PPE is in place and strong infection control mechanisms are in place. In the past 6 weeks, we are aware that no staff or residents have been admitted to hospital or sadly died as a result of COVID infections. Question 6. The Office of National Statistics figures for total death toll of care home residents, including COVID-19, between 2nd of March and 12th of June, show 74.9% occurred within a care home, 24.8% occurred within a hospital. How significantly can we expect the total Shropshire death toll to rise, currently reported at 105, including care home resident deaths in hospital and earlier deaths from COVID-19 in care homes, including occurring 2nd of March to 9th of April, are included? The board's answer is it is likely
Hi Val, it's Tanya here.
Hi, Julian's got a problem with his laptop. I think he's going to come and use mine. Just give us a couple of minutes. You're up. I'm taking over from you. You sit there.
Oops. Sorry, my laptop, despite being plugged in, has just died. I'm sorry, that's the NHS system for you. I think, can I just check that I'm on? You can hear me, Val?
Yes.
Yeah, so sorry about that. Shall I go back to question 5? I've just run into Dave's office, so I need to report to the NHS IT that I need a newer laptop, I think. So I think we were on question 6, wasn't I?
Yes, I think it was 6, Julian.
I've just read out question 6, and I was about to read out the answer. So I'm a bit thrown now. It is likely that the official government mortality statistics, 2nd of March to the 12th of June, will show a decrease in COVID mortality in both care homes and hospitals. COVID mortality is now defined as a death within 28 days of a positive COVID test. Previously, there was no time period applied to this definition. This does not change the significance of every COVID-related death. The current total out-of-hospital deaths to September 20 are 112. This data includes care homes. There have been no hospital care home deaths from the past 2 months, July to September 2020. So question 7, has there been any scrutiny of excess deaths not directly attributable to COVID-19 that sadly may have occurred in Shropshire care homes in April and May 2020? If there were excess deaths, what conclusions have been drawn about possible causes? The board's answer is we have analysed excess deaths. The specific analysis has been undertaken on all deaths, included COVID-19 related deaths. Shropshire data shows that there have been a total of 288 excess deaths. In addition to the data showing excess mortality during the period April and May 2020, the data also shows lower than expected levels of mortality in January and February 2020 and in July 2020. A significant proportion of the deaths during this period were COVID related, but not all deaths. Other deaths would sadly be due to the most common causes of mortality, including cardiovascular disease, cancers and COPD. So I'm very sorry to the public that halfway through or towards the end of the question that I disappeared briefly, but hopefully this is now back on track and working. And I can answer Lynn's question that is in the chat, and we shouldn't be using the chat. I had got my laptop plugged in with the light on, so I think there's something fundamentally wrong with it. So we move on to the agenda items. Each item is 10 minutes, including the question. So the first agenda item 1 is an STP update, which is a presentation. And can I ask the STP representative, Jill Robinson, introduces herself and presents this item, please.
Thank you, Julian. So my name is Jill Robinson. I am the STP finance lead, and I'm here today to just take you through a brief update of the work being undertaken across the system at this time. So
we might need you to go out.
Apologies, there is an echo, so I will change location to avoid that.
Yeah, sorry about that. That was obviously down to my previous problem of the laptop crashing coming in. And
apologies for that. I'm now in a separate office from Julian and David, so that should solve the problem. So if we can go through to the first slide, please. So what I will cover this month is an overview of the current situation, focusing on some key quality and safety issues and the overall system improvement plan, then look at the restoration and recovery, phase 3 planning, a verbal update on where we are with the system finances, and a brief update on the ICS development. So if we can go to the first safety and quality slide. And the next one. So this gives an overview for SATH in particular. As probably everyone is aware, in July there was another CQC visit which looked at medicine and end-of-life care, rating them as inadequate, and this is in addition to what had already been an inadequate rating for the urgent care. The focus then for the SATH team is to progress with the work on the conditional notices and looking at overall organisational improvement and development schemes. As you are probably aware, there has been a recent announcement of an improvement alliance with University Hospitals Birmingham. The new chair for SATH is also a non-executive director at UHB, so that will help with bringing those two organisations working closely together. The focus will be on how UHB can provide additional resources and leadership into the organisation to focus on the quality improvements. The key developments in this area will be providing a Getting to Good plan, which will be co-designed with both NHS England and Improvement and with UHB, and supporting the sustainable quality improvements. This partnership has started from the 1st of September, so is very, very new development. Looking at our other providers within the system, the Shropshire Community Healthcare have highlighted that the looking after children's services, there are a number of hosted children across both Shropshire and Telford and Wrekin which require health assessments, and they're putting in improvements in this respect. You have also the Midlands Partnership FT, which provides on the mental health, and the LD&A annual check. So those are the sort of health, quality and safety risks that we're focusing on in the current environment. If we go to the next slide, one of the outcomes of the recent board to system meeting we had with NHS England and Improvement is the identification that as a system we are putting together a very detailed plan that will focus on how we can support across the system to SATH to ensure that the good to great plan and the quality improvements that they are focusing on in the individual organisation, we are also ensuring that we are doing everything across both the other providers and within the commissioning organisation to support that improvement plan. So specifically, we will be looking at quality, patient safety and culture, the emergency department staffing and estate, the Ockenden report, and also what needs to be done to support the hospital transformation programme. This improvement plan will be developed and taken to our integrated care board on in September, with an update in the October meeting. So we go on to the next slide. The key elements of this plan will be the support that the system can give across demand management and looking at clinical variation. As I've mentioned, the hospital transformation programme, any centralisation of services across our providers, supported specifically by a detailed people plan and workforce strategy, the ongoing work that we have with the integrated care system and the integrated care partnerships, and of course will be underpinning the overall system efficiency and financial sustainability plan. If we go on to slide 9, this gives an update on where we are with the restoration of services following the COVID-19 pandemic. Specifically, we are progressing very well with the restoration of the services, although given the social distancing requirements and other staffing requirements, the actual throughput within the services is not necessarily at the level that it was pre-COVID. But if we look at where we are on the actual services, we've got elective inpatients is at a level that is commensurate with other areas across the region and is increasing significantly with the trauma repatriation back to South. Urgent referrals are at the pre-COVID levels. 2-week referrals recovery is at a significant level, although we are still noticing only 50% for both lung and UGI. Diagnostics is a particular concern, and we have a plan to actually focus on getting the CT scanning back to where it should be by January, and the MRI will take slightly longer, and that is on track for March 2021. Primary care services are almost 100% restored, and overall as a system, out of the 106 services that were impacted, 44% are fully restored, 34% partially restored, and we have about a quarter of those that we are in the progress of restoring. If we then go on to the next slide. As I go through, yeah, okay, thanks David. So yes, apologies that the NHS does use a lot of acronyms, so as I go forward I will endeavour to articulate all of those. Moving into the phase 3 planning, the NHS is now in the process of putting together the operational plans for the remaining 6 months of the financial year. This will focus on these 3 main priorities. So accelerating activity to as near normal levels as possible on non-COVID health services, preparing for the demands of winter as we enter the winter period, and also looking at the ways we can take the improvements and the lessons learned that we've experienced during the first COVID peak and make sure that we lock these beneficial changes into our plans and support staff, as well as looking at the inequalities and prevention. So if we look at the next slide, the planning approach that we have for this this phase 3, we are very much working together as a system. So we have a system-wide planning group that is joining together to make sure that we have the same assumptions going across the system. We're focused on the main priorities. We're looking at the fragility of the system and understanding where we need to be putting in the extra support. So it's specifically looking at workforce estates, the rurality and the inequalities agenda. It will incorporate absolutely our plan for the winter, so looking at our bed capacity across both the acute and community sectors. It will focus on the integration of how we can actually shift the activity away from the emergency department at South and into community and local care as much as possibly can. That we do have a robust data challenge, which we are very much working on. We are looking at the future alignment to population health management and understanding the impacts of the services on a place basis. However, all of this needs to be looked at in the realm of what is affordable as well as what is achievable. So looking at our scarce resources, which are primarily around finance and workforce, then understanding the risks of the priorities we will need to look at and what the constraints will be. We're working very closely together with NHS England and Improvement and addressing the additional capacity both from a financial point of view and a staffing point of view that we will need. So that's really the approach for the phase 3 plan. This plan is in development at the moment and will be taken to the Integrated Care System Board in next week, and the first version of this plan will be submitted to NHS England at the end of September. If I skip through to the finance situation, the first 6 months of the year, the costs of COVID have been underpinned by 3 real mechanisms. One, we have provided block payments to our providers from the commissioning organisation to give security of funding for the main activity going through all the provider organisations. This funding is then also supported by a prospective top-up which focuses on the expected costs of COVID, and then retrospectively those costs are reviewed and have been fully funded by additional financial support, so that overall for the first 6 months of the year all of the providers and the commissioners are in a break-even position, so everything has been fully funded. Going forward, we are still waiting for agreement with Treasury as to what the full financial support will be for the NHS, but the expectation is that the block funding will continue for providers, which includes an assessment of the funding needed for winter planning, and will also continue to have an element of COVID top-up funding, which will be granted to the system, and the system will then allocate that across to the providers as needed. What is not known at this stage is the extent of that COVID funding, but we expect to have notification of that in the next days, so that will then be used to inform overall our phase 3 planning. The next section is on our integrated care system development. This is a programme that is looking at getting every system nationally in place to be operating as an integrated care system by April 2021. We have taken various steps during the current year to establish the Integrated Care Board and the leadership team across the system. We are now looking at putting in place the various programme boards and enabling groups that will support the overall system work. These are established with a dedicated director level resource leading the group, and includes not only representatives from the NHS, but also from local government and increased involvement of both voluntary and community partners. And those groups which we had suspended during the COVID situation, we are now using actively as we move into the restore and recovery phase, and almost all of those groups are now back up and running. This therefore will mean that we are starting to focus not only on the immediate restoration and recovery, but also starting to look at the longer term developments for the system and the transformation of services. If we go through to slide 17, we are already in progress with streamlining the commissioning approach, and we have our application in for 1 CCG across the system. So that is, we have already established a single executive team, and effectively from the 1st of April we have been working operationally as 1 CCG. We are now looking at the formal approval from NHS England and improvement that we can move that to a statutory organisation with effect from the 1st of April 2021, and we're expecting confirmation of that shortly from the national team. On a digital perspective, on page 18, we have a plan for implementing a full shared record. So the system-wide plans and approach is in development. We're building on the good practice that we've identified during COVID-19. We have identified and prioritised additional funding support for that from a system. Additionally, we are working on the population health management and business intelligence function. We've identified this as a key priority and looking to establish one system across the whole system. And we will work with NHS England on a development plan for population health management. So that's rather a lot of information that I've downloaded in a short time. So please let me know if you have any questions.
Thank you, Jill. I can now, if I can now ask members of the committee for their comments. Could you please indicate on the chat function if you wish to speak? And please remember that when asked to speak, members should unmute their microphone, state their name and remute on completion. So are there any questions for Jill on that quite detailed presentation? I'm not getting anything coming up in the chat bar. I've got Maggie Bailey who'd like to make a comment. So Maggie, you went. Sorry, I may have to introduce yourself because you went here at the start of the meeting, unfortunately.
I'm very sorry, there was some technical difficulty sending me the Teams link meeting. So I'm Maggie Bailey. I'm the outgoing interim chief nurse from SAF and here representing Louise Barnett, chief executive today. I just wanted to make a comment to clarify some facts. The CQC visit occurred to the trust on the 9th and 10th of June. It didn't occur in July, just so everybody's aware of that date. And I also wanted to let you know that the trust has had an improvement plan in place in relation to CQC actions that have been implemented within the organisation, and currently we've implemented from May 74% of those actions to date. So I just wanted to update the members and the public in terms of the progress that's being made in the organisation to make the changes required, as well as looking forward to working collaboratively with UHB as part of the Quality Improvement Alliance.
Okay. Thank you, Maggie. I've not had any other comments in the chat, so I'll just ask to make sure there's nothing else that Jill wishes to clarify. Jill, is there anything you want to clarify, or is there nothing further to add?
No, I think that's everything. Thank you, Julian.
Okay, thank you. So if there are no more speakers, the recommendation is to note the SDP update provided through the presentation. Please could I have a proposer and a seconder?
I can propose, Julian.
Thank you, Rachel. And I think Dave has indicated he's seconding it.
I will second it.
So I will now accept the recommendation to note the SDP update report provided through the presentation, unless anyone else indicates differently. So, sorry, Lynn, you want to make a comment? Sorry, whether the comments may be coming through quite slowly, but thank you. Yes, do you want to make another comment?
Yes, thank you. This is Lynn Corley, Chief Officer for Healthwatch Shropshire. I just wanted to state on record that I think it would be really helpful for the SDP report to explain all the acronyms that are used within it, because this is a public meeting, and I just think it would be really helpful for any members of the public joining us to understand the detail. Thank you.
Thank you. So I think if we could attach to the report, Jill, a list of the different acronyms that we use throughout the report, like DMO1 and MRI, and things that we know quite easy in the NHS, but I think are probably a bit vague to most people outside a small clutch of us at the CCG. So with that comment, can we now, can I have, Rachel, are you happy to re-propose the that we note the SDP presentation with that change?
I am, yes. Thank you, Julian.
Dave, you happy to second that?
I am.
Thank you. So I can now accept the recommendation to note the STP update report with an appendix of some of those of all the acronyms used in the presentation, so the public, when they read it, are aware what they mean. So thank you very much for that, Jill. Move on to agenda item 2, which is the Shropshire Care Close to Home update, which is again via presentation. Can I ask Lisa Cliff to introduce herself and then present this item? I do perhaps need to remind people we are trying to keep most presentations quite short and precise, and have to allow some time for questions and discussion. So Lisa, if I can hand over to you.
Thank you, Chair. So my name is Lisa Cliff. I'm part of the group working on the community and primary care place-based group, and I attend this board regularly to give updates on Shropshire Care Closer to Home. Could I have my presentation up, please? I'm not seeing my presentation. Is everybody else seeing my presentation?
No,
Not at
not
the moment,
yet.
Lisa.
No.
There we go. Could I have the next slide, please? So I thought it was important to start the presentation really with summarising where we were. Shropshire Care Closer to Home was one of the transformation programmes that reports to the Health and Wellbeing Board, and as I said earlier, receives regular updates. The programme of work at that time, as summarised in this slide, was around the frailty intervention teams that was operational at the Shrewsbury and Telford sites, and phase 2, the risk stratification and case management demonstrator sites that were operational in 8 GP practices. Both of those schemes were working well, and we were receiving good feedback and really good case studies from members of our public around the care that they were receiving. And phase 3 was around the hospital at home rapid response and crisis models that we were designing collaboratively across the system. Those models were developed, they were impact assessed at a system level, and were signed off by all of the governance across the system. We also had a winter admission avoidance service in December, working from the Shrewsbury locality, where we received some really good results in terms of protecting the front door of the acute. We did have some staffing issues around that over the winter, but there's a lot of learning that was achieved through that scheme, and all of the work was underpinned by the STP enablers of workforce and digital. And we were the first programme across the system to share information across all partners. So we were really making some fantastic progress, and we received a lot of praise from this board for that work. We had implementation plans from November 20 to take case management across the system, and a wide range of learning around that. Next slide, please. So what happened is that the programme was paused in March due to the crisis response to COVID-19, and the workforce within those multidisciplinary teams that were working around the GP practices were redeployed to undertake the crisis response, and as were many of the staff across the system, including myself. So next slide, please. So where are we now? moving on from Jill's presentation, really, the Shropshire Care Closer to Home programme has really, the scope has been redefined. It's now not a 65+ model. We're looking now at an all-age model, and we're working through as a system in terms of restoring services as part of the national response, and actually the recovery of services in terms of what transformational change are we taking forward, what learning do we have that we've gained through this period of crisis. We're working very much as a team to look at what our priorities are around winter planning, and then in the longer term, how does all this change our big ticket transformational items. So whereas Shropshire Care Closer to Home was just focused on those 4 areas that were on the first slide, we now have got a much greater scope, and we're working very much on what the priorities for that work will be. We've only had 1 meeting that met in August. You'll be pleased to know that the case management and rapid response and the learning from that still continues. We still want to take forward that work, but the scope has been very much extended to include children's physical health and personalised care. There's a range of priorities that we're working through. We feel very much that taking this approach that we can ensure that how we restore services supports what we need for winter, but also what we need in terms of transformational change for the future. Next slide, please. I thought it was important to share this slide. The NHSEI have set up a strategic cell in terms of winter and admission avoidance for winter, and they see that these are the key work streams around there, which is around supported discharge, right care, right place, right time, and care homes, and very much Shropshire Care Closer to Home through the community and place-based cluster board want to oversee and deliver elements of this work, so you can clearly see how the scope of the programme is changing. Next slide, please. So where are we now? We had our first meeting of the new programme board in August. We're working through our priorities, as I said earlier, in maintaining case management and rapid response, but undertaking some additional work. We're looking at our models of care that were developed before COVID and saying, do these need to change? Obviously, the acuity of people has changed, the population need has changed, and we need to be able to be flexible to change those models. We're looking at what our outcomes might be and the learning that has taken place as well to see what we can move at pace. So we're looking at our existing progress, so that's from what the work we've undertaken so far, but also in terms of any lessons learned in this period. And by the 5th of October, we will have had to articulate to the cluster board the overarching outcomes for the programme, but the delivery models and plans for winter and for the immediate term for community. Next slide, please. I'm going to pause at that point if there's any questions. I appreciate that's a lot of information, but it was important to sort of revisit where we were as a programme and our future direction of travel, but hoping that I'll be invited back again to be able to give a more detailed update once our delivery plans have been developed. Thank you.
Thank you, Lisa. So if I can now ask members of the committee for their comments, again, please indicate on the chat function if you want to speak. Please remember when asked to state who you are, unmute after you've unmuted your microphone, and then remute on completion of your comment. So please, any comments, questions, please, if you could flag your name up in that. Lynn.
Hello, it's Lynn Corley again, Chief Officer for Health Watch Shropshire. Lisa, I just wanted to ask if members of the public are listening to this presentation and think that this is something that they or a family member would benefit from, how can they find out more information about the programme and their eligibility to get involved?
As part of the previous programme, thank you, Lynn, you'll know that we did extensive communication and it was on the website of the CCG. We're working now as we extend our scope to refresh those pages to ensure that we have mechanisms for people to come forward, but as we're redefining, that detail isn't actually available yet until we've got those clear delivery plans around who, what, when and how. We need that detail first.
Thank you.
Okay, thank you, Lynn. Thank you, Lisa. Any further questions? Again, I'm looking in the comments bar and can't see anyone. I mean, it's good to have that update, and it will certainly be good to bring that back to the Health and Wellbeing Board as things develop and as we go through the next few months. Is there anything, Lisa, that you need to clarify, or have you got anything else to add before we move to accept the report?
I'd just like to thank all of the teams and the partnership working from across the system for what we achieved prior to COVID, and actually the extensive learning as part of COVID that really does benefit us going forward. And I'm very happy to come back and update that position to the board in the future. So thank you for the offer.
Thank you. So if there are no more, sorry, Dean is having some connection problems, and but I don't think he's got a question to raise, so we just need to be mindful of that. So if there are no more speakers, the recommendation is to note the Shropshire Care Closer to Home update provided through the presentation. Can I have a proposer and then a seconder? Obviously, there's only limited numbers of people who can propose or second.
I'll propose, Julian.
So Dave will propose it, I think.
I'm happy to second it.
Thank you, Rachel. Rachel Robertson will second it. So I now accept the recommendation to note the Shropshire Care Close to Home update provided through the presentation. And again, unless anyone else indicates otherwise, through the chat feature. If not, we then move on to agenda item 3, which is the Better Care Fund paper. Can I ask Penny Basin to introduce herself and present this item, please?
Thank you, Chair. I'm Penny Basin, STP Programme Manager, and support the Better Care Fund as part of the work that I do. So we don't have a presentation for this, but we did provide a paper, and I guess there's a few key, I'll just pull out some key points, and then just for the 2 areas that we asked for the board to agree. So the key points are that the Better Care Fund continues to support integrated working within Shropshire, and the 3 key areas of focus are prevention, admission, avoidance and system flow. Now, the Better Care Fund, as you know, has carried on for some years and has remained, from our point of view, quite stable over the last few years, and we have maintained our priorities. And again, within the planning for this year was advised nationally, and we've worked through that locally to keep our kind of the Better Care Fund stable, and we haven't adjusted too much. We've rolled it on, I suppose is what I'm saying, and we haven't adjusted those key areas of work. We've kept them the same. Of course, COVID-19 brought about some interesting challenges for our integrated working. So just highlight a couple of those things. There's, as part of the Better Care Fund, there's 8 high impact change model, which is really about system flow. And actually they've added, over the last year, they have added an additional impact area, which is housing, which is really important, as we know, for that system flow. And so that was a welcome change. The 8 high impact model has been updated to include considerations around COVID. So I think, as we know, COVID has really shone a light for systems and probably provided some impetus in some areas where we were very able and very quickly able to change our processes to move people out of hospital quickly, and also to stop people going into hospital. And I think that's been given us sort of those key areas now where we can continue to focus on, and the 8 high impact model sort of reflects those as well, those good practice areas. I think the key areas for this paper that we wanted to look at is to highlight the performance report. So it's quite late but we're not late. The system nationally, we were asked to input our Q4 from the end of 1920 on last Friday. So this has already gone in, but we are still asking the Health and Wellbeing Board to endorse it. The requirement for reporting was reduced. However, we were able to provide much of the information that has always been asked for that quarterly reporting within the performance report. And so the key areas around that performance is that I think we had COVID to thank actually for being able to meet our non-elective admissions, which I suppose is no good thing, but we weren't on target to meet that until COVID, and then we have met that. We have met that target. I think all our other reablement targets have been met. That's in the quarterly monitoring which you have received, and some we highlight as Lisa has gone through the care closer to home as our success story, as our integration success story, because of all that really positive work that's gone on there, which has been fabulous for this system. And so the board is asked to endorse, and at the end of every year as well, there's a tab within the quarterly monitoring asking us to provide feedback to our national bodies around what we think of the Better Care Fund and the ways in which it has or hasn't supported, and that's provided in the monitoring as well. And I think for us, we feel that the Better Care Fund does provide a platform for us to improve our integrated working, and it does provide pause for thought, if nothing else, about how we can do things better and do it more collaboratively, and I think we do that well. The other key area within the report to look at is the COVID-19 additional grant funding was provided for us to move people out of hospital in relation to COVID very quickly, and also to stop people going into hospital very quickly. Now, that grant fund is required to be part of the Section 75 partnership agreement that has been signed by this board previously. So with this, we must make an addendum to the agreement, and the schedule appendix B is the schedule that we've provided that highlights how we're going to do this. It has been worked on and agreed at the Joint Commissioning Group, and is for you today to endorse as well. It highlights, I mean, I think just to say that we are working collaboratively around this joint fund. It's working in practice. We're already doing it. This schedule formalises the agreement across the organisations. But very happy to take any comments and questions. Thank you.
Thank you, Penny. I thought it was a very useful report. I think things about the integrated hub model and the way we've seen better working together through COVID is one of the major positives that's come out of it. But if I can now ask if other members of the committee, if they wish to comment, and again, if they could indicate on the chat function if they wish to speak. And again, please remember when you do speak to introduce and unmute your microphone, introduce yourself, and then after your comment, remute on completion. So Tanya Miles.
Good morning, committee. It's Tanya Miles. I'm the AD for Adult Social Care and Housing here at Shropshire Council. It's a comment really, just to acknowledge the system. We've got a really good track record in discharging patients from hospital in this system, one of the lowest delayed transfers of care in the country pre-COVID. But with the new integrated hub model, what this team has achieved is quite staggering, in that we're now discharging a ward full of complex patients per day. So for this system going into the winter, in light of the potential kind of bed gap issue that many systems will be facing, we're in a really good, strong position. So to publicly say huge thanks to the integrated hub team that have worked incredibly well over the last few months, because 28 complex patients a day, that's a whole ward of patients coming out of that acute hospital. And just to ask Lynn in Healthwatch just to kind of comment on the Healthwatch survey that we're about to launch, to get feedback from patients and families that have gone through this integrated discharge model over the last few months. Thank you, Chair.
Thank you, Tanya. Lynn, would you like to comment about the survey?
Yes.
Any other feedback, obviously.
Yeah, that's fine, and it does appear in my presentation in a little while. Yeah, so Healthwatch England, as our national body, had launched earlier on this year a discharge survey, but we've decided, because you know, we've got quite a complex system in Shropshire with a trust across 2 sites and the 2 councils working with the same provider. So we've worked with the people who are working within discharge at the moment to make sure that the questions we're asking in our survey are the right questions. And a press release will be going out this afternoon to promote the survey that's being run across Shropshire and Telford and Wrekin. It's being hosted on the Health Watch Shropshire website, but as I say, we also want comments from people who live in Telford and Wrekin. And also we're promoting our phone number so that we can support people to complete that survey over the phone to try and prevent any digital inequality around the survey. So for me, it'll be an important way of us recognising the work that the team have been doing, but also being able to evidence how the patients and their families and the professionals involved in those discharges have experienced the current system. So we're hoping that we'll get a wide response to that.
Thank you, Lynn. Any further comments? Certainly the committee, would back up Tanya's comments. Would like to thank all those staff that are working very hard in the integrated hub team. And as you say, that's to be discharging that number of patients on a day-by-day basis. Has been of huge benefit to the system and to patients and their families clearly as well. So thank you. Any further comments from anyone? I'm looking for anyone flagging themselves up in the chat bar. I'm not seeing anyone. So Penny, are there any further points of clarification that you wish to clarify? Anything you want to clarify?
I suppose just thanks, Julian. I suppose just on reflection, just to say that the system, as Tanya mentioned, that discharge and emission avoidance, that the enormous work that went in and how quickly the system responded to be able to do that was amazing. The other parts of the system that the BCF uses, that's funding to integrate as well, such as the social prescribing, Let's Talk Local, the other areas, they all adjusted very quickly. Staff were working all hours to think about how we can continue to offer services to people at a really difficult time and support people in different ways, working across the voluntary sector. So, and the voluntary sector, of course, we had at the previous Health and Wellbeing Board, we had a detailed report about how that discussed how the voluntary sector really and the community really supported each other through COVID, but also, some funded programs adjusted as well. So I guess I just wanted to highlight that as well as part of this report. Thank you.
Okay, I've got Jackie Jeffrey wants to come into the discussion as well. So thank you, Jackie.
Hi, yeah, thank you. I'm Jackie Jeffrey, Citizens Advice, Chief Officer of Citizens Advice Shropshire, but also I'm the voluntary sector Assembly rep on the board. I'd just like to reiterate the response that the voluntary sector in Shropshire's had, and thank you, Penny, for raising that. And just to ask, really, has there been any capture of the changes that the voluntary sector has made that's fed into your reporting on the Better Care Fund to national? I think it's something that we should applaud. I think the way, in fact, the whole voluntary sector, not just voluntary sector assembly and commissioned voluntary sector organisations have, but also the mutual groups that have set up and have responded. We've got Emily coming on later, around at the Shropshire Food Poverty Alliance and all of that. Is there been any way to capture that and feed it back?
So
Penny, don't respond to that.
Yeah, thank you. That's a really good point. So we have done a survey through the Rural Community Council, which the results haven't, I think they've probably been analysed, but we haven't worked with the RCC yet to look at those. But I think that's one way in which we can help provide some of that feedback. We've obviously reported at a system level to around the work that's gone on and the amazing response of our communities and our voluntary sector. So far, we haven't reported up through the Better Care Fund, but with the quarter, we're behind obviously with our quarterly reporting, so we'll be able to do that with the next quarterly reporting in the Better Care Fund. That will actually be for the time frame of COVID. The quarterly report in this report is from pre-COVID, so that's a really good point, Jackie. And I don't know if others have other thoughts about how, really welcome other thoughts about how we could report nationally, but there's certainly opportunity through the Better Care Fund to demonstrate good practice, provide case studies. They're always keen on seeing case studies of what's happened around the country, and so we can do that, and we can do that through the quarterly reporting, and happy to take any other suggestions of opportunities of how we report that up.
I think that's really important. You've got prevention there as a big kind of theme of part of the Better Care Fund. So any case studies or measurement on actually the prevention that you've helped to stop people getting further into crisis would be, I think, would be really good to shine the flag in Shropshire. Maybe Emily's got an idea. Sorry, yeah, Emily.
Thank you. Perhaps if people could submit some ideas to Penny, unless there's anything they want to bring up now. I mean, certainly the voluntary sector and the volunteers are, certainly in general practice, our care coordinators have been invaluable, as has the local sort of community in terms of supporting other patients. So it's really important to acknowledge all that work. And I think if anyone has got any ideas of how to reflect that better, then probably if they could direct their comments towards Penny, that would be really, really good. Is there anyone else who wants to bring up anything? Otherwise, we do have two recommendations. The first one is that the Health and Wellbeing Board endorse Appendix A of the Better Care Fund performance template and metrics, and the second one being the Health and Wellbeing Board endorse Appendix B, Schedule 1, addendum to the Section 75 partnership agreement. So once more, if I could have a proposer and a seconder.
I'll propose, Julian.
Dave is proposing, Dave Evans, the Accountable Officer of the CCG. I'm not sure Dean is able to hear us very well, but obviously there's only a limited pot of other people who can second it. So,
I can hear. Was the request for a seconder?
Yes, it was Dean. Yes, yeah.
Yeah, I couldn't hear all of the presentation, but I am familiar with the presentation, so I'll happily second.
Thank you very much, Dean. Thank you. I do realise you're having problems with the connection. So I can now accept the recommendation to the Better Care Fund report, unless anyone else indicates they've got anything else to add. No, no, that's brilliant. Thank you. So if we move on to agenda item 4, which we've already begun to touch on, which is the healthcare, social care and wellbeing services during the COVID-19 pandemic, and can I ask Lynn Corley to introduce herself and present this item, please?
Thank you. Could we move on to the slides, please? Next slide. Hello, my name's Lynn Corley. I'm the Chief Officer for Healthwatch Shropshire, and I just wanted to thank the Health and Wellbeing Board for the opportunity to feed back on an important piece of work that we did early on during lockdown. This is when the country went into lockdown. Healthwatch Shropshire had to change the way we were working, as did many other organisations, and when we could no longer do face-to-face public engagement, we decided it was important that we ask the public their experiences of healthcare, social care and wellbeing services during the pandemic. And we ran the survey from the 9th of April to the 31st of May. And this presentation is just a summary of the findings and our recommendations from that report. If you'd like to go on to the next slide. It's probably also useful to mention that during the survey itself, we produced interim reports each week so that we could share with the system, health and social care system, our findings as we went along. In total, we received 568 responses from across Shropshire. And because of how the internet works, we also did hear from people from Telford and Wrekin and shared those responses with our colleagues at Healthwatch Telford and Wrekin. I think some key points is that it was really good to hear that 93% of people said that they had found clear and accessible information about COVID-19 and what they should be doing during the pandemic. But it's also important to note that people were still asking for more clarity about shielding, PPE, social distancing and enforcement. And I think as this situation continues to evolve and move on, I think it's important for providers and community groups and the council to continue to send out the messaging because inevitably there will continue to be some confusion. In terms of shielding, should that group need to shield again, I think it's also worth noting that there were some people who felt that they should be shielding, but they weren't sure if that was the case. So it's something to consider going forward. Not surprisingly, 64% of respondents said that the experience of the pandemic had had a slight or a significant impact on their mental health. And 283 respondents went into detail about that. And we were able to share those responses with the mental health resilience and prevention meeting that we were attending each week, so that could be taken into consideration when planning the mental health resource that is now available on the Shropshire Council website, and also any ongoing support through voluntary and community sector organisations such as Mind. If you could go to the next slide, please. As part of the questions, we asked people if they were working during lockdown, and inevitably we heard from people who were key workers, and that group reported that they'd had the most significant impact on their mental health, with 18% of those people saying that they were worried about working during the pandemic, safety in their workplace, redeployment, and their concerns about taking COVID-19 home to their families. The key workers weren't restricted to health and social care. We also heard from people who were working in the police force at that time. Overall, 20% of people caring for an adult reported that there'd been a significant impact on their health and well-being, and the comments that they shared illustrated the impact of the loss of formal and the informal respite during the lockdown, when groups were ended and formal services closed their doors, and they felt isolated. And I know that work was done to reach out to those carers to make sure that they were coping. 40% of all respondents said that their healthcare had been affected, in particular with cancelled appointments at the hospital, difficulties getting primary care appointments through their GP practices, and obviously dental services had closed, and there was confusion about how to access emergency dental treatment. But we also heard from people who had the opportunity for face-to-face appointments, but had decided not to attend because of their worries about COVID. And I know that the system is keen to send out messages now about the availability of appointments and then the importance of attending those appointments if they're offered, in order to get diagnostics and treatment. 10% of people said that their social care had been affected, but as we joined the community response meetings led by the council, we were able to feed that back, but also hear about what work was being done to try and continue services as much as possible for those people receiving social care. But we also wanted to hear about what people had found most helpful in terms of self-care and coping strategies during the pandemic, so that could be shared more widely. If you'd like to go to the next slide. Okay, so we made some recommendations, and we knew at the time that work was already being done to progress some of these, and I'm sure that since the publication of the report that's continued. So it was really clear to us that the importance of clear, accessible information continued after the lockdown and while this situation changes. If you'd like to go to the next slide. We also have been reminding health and social care providers of the importance of keeping in contact with patients and service users so that they know that they haven't been forgotten, even if it's not clear when a service can restart, that reassurance that they're on the list and that they will receive information in time, I think is really important. If you'd like to go to the next slide. I think it's recognised that the pandemic will continue to have an impact on people's mental health and anxiety over the next months, and so it was about ensuring that there is an offer across the county for people to help them to gain in confidence. Particularly, we know that there's people who are still reluctant to leave their home and access services. We also highlighted the importance of supporting carers because they're so important to the system, and we just felt that there was probably more work that could be done in that regard. And if you go to the next slide, please. And for me, it was also about prevention, really, and the importance of reminding people about healthy eating, exercise, and those self-care routines that people had told us were so beneficial to them during the lockdown. And if you'd like to go to the next slide. So the findings from the survey have enabled us to plan our next steps. And from what we heard from people in that survey, we decided to do a hot topic, which means that we've put a call out for people to share their experiences of phone, video and online appointments, because this is an important part of the long-term plan. But we also know that for some members of the population, it can be challenging. It might be something that they're not familiar with, and it might be something that they don't want. So we're keen to hear where that's working well, where the challenges lie, and we'll share that information with the system when we've produced our report. The next slide, please. So we've also, we're in the process of launching our discharge survey, as I've just mentioned, and we're also doing an out-of-hours palliative care survey. So this is to find out people's experiences of palliative care during the pandemic. And through that, we're also hoping to get some feedback on the palliative care helpline, which was set up by SHROPDoc during the pandemic. And as I've mentioned, we're also running the discharge survey as well. So I think that's the last slide. So if anyone has any questions.
Thank you, Lynn, for that, and thank you for those 5 key sort of recommendations that were drawn out from your report. Can I now ask members of the committee for their comments? Again, please indicate on the chat function if you want to speak, and then obviously unmute, tell us who you are and your question or comment, and then remute on completion. So I have a couple of people already in the chat bar. We've got Rachel Robinson first.
Thank you. It's Rachel Robinson, Director of Public Health, Shropshire. So thank you, Lynn. That was a really interesting, really useful presentation and piece of work. And just I think it's sort of just really more of a comment than questions. Certainly, you know, I recognise, and we've had a lot of feedback around the need for people to have clear information and guidelines, and that's something that we've continue to try and support as the guidelines have changed throughout the pandemic, and obviously we've had new guidance issued that will come into effect on Monday that we're working through, and making that really clear to people as it continues to be a challenge, but is absolutely crucial to the work that we're doing. So it was to recognise that and the ongoing work through our comms and through colleagues to make sure that we get clear messages out.
Can I respond to that? That's really helpful for you to highlight appreciate that, Rachel. What people were telling us was really interesting, because a lot of people were obviously getting the information from national government through the daily reports and also the national press. But obviously they were also using the Shropshire Council website, as you would imagine. But what was quite interesting was a lot of people said that the information they were being given by their employer was the most helpful. So I just wonder if the system is sharing the information with employers so that it can be added to their websites and in their communications with their staff.
Thank you, Lynn. I think that's really helpful feedback and detailed feedback to have. We certainly are working really closely with businesses and providing information, but I think that specific point about whether people are sharing that in their intranets or through their staff emails, etc., would be really useful we can follow that up. The challenge we've had from the start is that obviously locally we reflect the national guidelines, and they have changed quite quickly. The frequently asked questions are really, really useful on the national sites as well as local sites, but I will follow up that specific point. I think that's really, really helpful feedback to have, so I'm happy to follow that up.
Yeah, so for example, the police staff particularly said that the information they'd had from the police force was very useful.
Okay, thank you. I think we've got two other people with questions or comments. We've got Ros Preen, who I think, again, you weren't here right at the start of the meeting, so you might have to, presumably you're substituting for David Stout.
Yes, I am. So yes, I'll do that, Julian. I'm Ros Preen. I'm the Director of Finance and Strategy for SHROPCOM, and yes, as you said, I'm deputising for David. I just wanted to make a comment, really, because just wanted to give Lynn some feedback about how useful this kind of survey is for healthcare providers. We've looked at the Telford equivalent, and we'll be obviously sharing internally the outcomes from your report here and considering the recommendations. It's a really important piece of feedback for us as we're restoring services to bear these things in mind, because they do apply now and into the future. So I just wanted to say our board really welcome these reports, and the future ones that you've highlighted also. I think we touched at the last Health and Wellbeing board about how important digital was, but it wasn't for everyone, and so that survey that you're doing around digital is going to be really important to us as well, because it's a key feature of how we're looking to develop, but not over emphasise and over rely on digital for patient access to our services.
Okay. Penny Basin would like to comment, and we need to go back to Rachel Robinson, who's got a further comment. So Penny.
Thank you, Chair. I just wanted to say, Lynn, that we have had draft guidance and we're expecting it to be formalised going forward around shielding. And so there is some work that we can do collaboratively, and conversations I think are happening today with colleagues within the council and the voluntary sector around thinking about next steps for shielding. And so I was just thinking as you were talking about that there's really some good work we can do together, I think, going forward with the voluntary sector and with others. And so it was really, I guess, important to hear you talking about that and some clarity, I suppose, for those people again, and that comes back to that whole communication message as well. But you know, the shielding crosses obviously particularly into connecting with primary care, and then ensuring that those people have the support that they need in the event of a local lockdown, or if shielding rises again. And I think the other thing to say about that is we're seeing on the news that local lockdowns are happening. So should a local lockdown happen, it doesn't necessarily mean that people will be asked to shield again. One doesn't have to come with the other. So again, it's just around making sure that we're really clear in our messaging and people really understand some of those things going forward. And the other thing I just wanted to mention was mental health resources. So you mentioned mental health a number of times, and I think it is vitally important. I just wanted to make a plug here for the Together All platform that Shropshire Council has invested in, which is an online platform for 16 plus. So we've had online platforms for younger people for a couple of years, but actually this one's for adults, for anyone living or working in Shropshire. And so that provides a real, it's a really useful tool. I've had a few looks at it, and I think it's really good, and there's opportunities there, and there's safeguards within that tool as well to make sure that if people are really struggling, that there's some checkpoints and balances so that people aren't left struggling if they're really at the brink. And then the other plug is for bereavement counselling. So there's been investment as well, working closely with voluntary sector to stand up additional support around bereavement at this time, and that's accessible to anybody living in Shropshire. So I just wanted to make those 2 points around mental health. Thank you.
Thank you, both 2 key points. Then we'll go to Rachel, then come back to Lynn for some final comments and thoughts. So Rachel.
Thank you. So yeah, I mean, Penny's actually covered a lot of what I wanted to cover. I was going to mention at the end, but I think the work that that Healthwatch have done is pulled out some of the really concerns that we've had from the start around mental health. And as we heard last time, and as Penny's just said, there's an awful lot of work going on around mental health and needs to continue to happen. Obviously today is World Suicide Prevention Day as well, so just obviously to remind people and highlight that to people. And this time last year we were launching our new cards, Z cards, but we have got a range of resources that are pulled together to focus on looking after your mental health during COVID, but also the resources that Penny's mentioned. So I really just wanted to flag that we are updating the Looking After Your Mental Health Guide. It has been recognised nationally, and it does pull together some of those wellbeing resources, but it does need to be updated, reflecting some of the feedback that's in the work that Lynn and colleagues have done. So I just really wanted to highlight that. Thank you, Chair.
Thank you, Rachel. So Lynn, any further comment, anything you want to clarify or anything?
No, that's fine. Obviously, the full report and all the comments we've received from all 568 respondents are on our website. The idea being that every comment counts, and so if members of the system want to see exactly what people told us, then that is publicly available. But I also wanted to just remind the board that Healthwatch Shropshire and I believe Healthwatch Dartford and Wrekin have aligned our priorities this year to the STP priorities. And so if there's organisations across the system who'd like to propose a piece of work that we might consider doing, if they contact me directly, then we will take that to our board for consideration.
Thank you. So if there's thank you for that, Lynn. If there's no more speakers, the recommendation is to note the healthcare, social care and wellbeing services during the COVID-19 pandemic. Healthwatch survey responses provided through the presentation. Again, if I could have a proposer and a seconder.
I'm happy to propose, Chair. Rachel Robinson.
And Dave
I'll second.
Dave Evans is happy to second. So I will now accept the recommendation to note the healthcare, social care and wellbeing services during COVID-19 pandemic. Healthwatch survey responses provided through the presentation, unless anyone else has anything, and they indicate in the chat bar, which they haven't. So we move on to agenda item 5, which is a report on the current situation around food poverty. And can Emily Fay introduce herself and present this item, please?
Thank you very much, Chair. Can I just check my sound is okay?
It's perfect. Sounds
Great.
Perfect.
Thank you very much. So I'm Emily Fay. I'm the coordinator of the Shropshire Food Poverty Alliance. Can I have the next slide, please? So I just wanted to thank you for letting me come to talk to you and give an update on food poverty. It's been a very busy 6 months and so much has changed and so many people have been involved in supporting people with food. So I just wanted to give an overview of what's happened. So before COVID came along, really the main concern for us was around people not being able to afford food. But lockdown created lots of issues around people accessing food, particularly those who are vulnerable or shielding. So I want to start with food banks. They've had a really challenging 6 months. Many food bank volunteers and indeed coordinators fell into the shielding category, which caused sort of immediate problems for food banks. They're very small community-led organisations. So they needed to recruit new volunteers. They also had to change their operations so it was COVID safe very quickly. I know some food banks have had issues with people coming into food banks with COVID symptoms, which have caused further problems. They also very quickly saw an increase in demand. I mean, the demand has varied across the county, but in some areas that it was reported the demand was tenfold, in some areas it was fourfold. Other areas said the demand didn't go up at all, so it's been a really mixed picture. Food banks have received an enormous support from the community. They rely on community donations, but they've also seen support from local businesses. So, for example, up in Market Drayton, the local brewery lent their delivery drivers and vans to change their service over to a delivery-only service, which of course meant it was much safer in times of COVID. So food banks overall have coped really well, and we've been providing them with support throughout, but they're still facing issues around space for storage and also space to operate safely, particularly as they tend to work out of community venues that are now kind of reopening. In a number of parts around the county, we saw new food banks set up by communities. So for example, Bishop's Castle and Gabowen have set up new food banks. There are also a lot of projects in Shropshire that have been supporting people around longer term food poverty issues. So for example, community food projects, Shrewsbury Food Hub have been working with organisations like Martin Wilson School to expand their food share tables. So this is where anyone in the community can come and collect food for free. So there's no referral process in the same way that food banks operate. It's open to anybody who needs to come and get that food. And Osnosh over in Oswestry adapted their service by partnering with the food banks, so they were providing cooked meals that were delivered out to vulnerable people instead of doing community meals where people came together. So we've also seen a number of new community food projects develop around the county. So for example, up in Wem, we've seen the Wem Store Cupboard, which took a real partnership approach involving lots of organisations in the town to both identify local need but also get food parcels out to those who are struggling. I need to also mention the tremendous effort which has gone into ensuring that the homeless were housed and had a cooked meal every day. This has really reduced the pressure on food banks, but now these clients are starting to return. So lastly, there was the free school meal voucher scheme, which we didn't really expect to be rolled out in the way that it has, but it's really ensured that families on the very lowest of incomes have been supported with food, both throughout the term, but also for the summer holidays. So lockdown also created huge challenges for vulnerable people in terms of accessing food. In the early days, supermarket shelves were emptied due to stockpiling, and online shopping slots were really difficult to access. So many agencies worked together to ensure that those who were shielding or vulnerable had access to the food they needed. There was the government parcel scheme and lots of additional work done by Shropshire Council to ensure that people received parcels before they were registered on the government scheme. Shropshire Council helpline and the community reassurance teams also worked hard to make sure that everyone who was vulnerable could access food. And then we've had the amazing efforts by the mutual aid groups who've really worked at a neighbourhood level to help people with shopping and getting prescriptions and other essential services. We've also seen businesses really adapt. So supermarkets like the Co-op started taking telephone payments, which meant that elderly and vulnerable could order goods without leaving the house. In many cases, mutual aids went to pick up shopping and take it to them. We've also seen local fruit and veg wholesalers really change the way they operate to change over to a food box delivery scheme that were going out to lots of households. I think for me, the key learning from all of this is the role that local organisations played in both identifying need and creating avenues for support. So in some areas, GP practices have really played a crucial role in this. So in Pontesbury and Ludlow are the places that really spring to mind. And in other areas, it's the town and parish councils or local councillors. As Jackie was saying earlier, there's been so much community spirit, and I think it's really important that we continue to work with these communities and individuals to continue to foster this. And I think there's been so many partnerships which have grown, which if there are further lockdowns will be really important. Shropshire Infrastructure Partnership is really keen to provide infrastructure support to some of these new grassroots organisations. I think that's really hugely important. Can I have the next slide, please? So going forwards, I think it's clear we're going to see an increase in hardship, particularly over this winter, but probably into the longer term as well. Back in the spring, we saw a really dramatic rise in the number of universal credit claims. And there are huge concerns over what's going to happen at the end of the furlough scheme and what support there'll be for those who are self-employed. I've been working with Jackie as part of the hardship subgroup, and there are a number of key concerns that are coming out, specifically around housing, people who are at risk of eviction, those in private rented accommodations, and those who have a mortgage and whose income is dramatically decreased. There's also concerns about the number of people who've fallen into debt and the kind of employment opportunities going forwards for those who lose their incomes. All of these issues are going to have a huge impact on health and well-being. Food banks are already reporting a change in the types of people they are supporting. They're seeing more families, but they're also seeing new people who have never really expected to have used a food bank or indeed claim benefits before. So this group create a bit of a challenge because they tend to have high outgoings. They're never expected to lose their income, so they've got mortgage repayments. And existing kind of organisation and structures are not really set up to support them. The risk, I think, is that we're going to see more people falling into a chronic food poverty situation, which is where they're really going to struggle to have a healthy, affordable diet week in, week out. And I think we need to really think through what kind of support this group are going to need. As food banks are really just set up as a crisis response where you get a food parcel for a few weeks at a time. I think the key issue is making sure that people are aware of what support is available in Shropshire, but also encouraging people to come forward for this help, because sometimes people can feel that it's a huge stigma to come forward. Can I have the next slide, please? So the Shropshire Food Poverty Alliance have been working throughout the last 6 months, but also going forward. We're really grateful that we've had financial support from Shropshire Council, and we'll have forward funding going ahead as well. We're still working to the Food Poverty Action Plan, which I think is now more important than ever. And the key actions there are around enhancing emergency support for people in food crisis, increasing financial resilience, access to affordable healthy food through community meals, cafes, pantries, growing. And COVID has made us think more about older people and how they can access food, sort of Meals on Wheels services. And also initiatives which improve nutrition and cooking skills. Over the past 6 months, we've been working really closely with food banks. We've been running monthly meetings, providing them with help and support and advice. And we've been administering a number of grant schemes. So we've had a grant scheme from Shropshire Council and one from the Masons. And we've also accessed free food from DEFRA, which you can see a lorry load of food there in the picture. We're also working with food banks around signposting and developing local signposting leaflets so that people know where to get help in each part of Shropshire. Our key focus has been the relaunch of the Shropshire Larder website and associated social media. And this is really about information about how to access a food bank, how to ease a budget, and how to access advice if you're falling into hardship. So we're really focusing on linking people to the help which is available. Our other key focus this year is around children's access to food. I think the recent attention this has been getting due to Marcus Rashford's Child Food Poverty Task Force shows how important this is. He's really highlighting the recommendations from the National Food Strategy, which is around extending free school meals to more children, raising the value of Healthy Start, and working on holiday hunger. So we do have a bit of funding from a national charity called Sustain to work with rural schools around food poverty. and we're also working to promote Healthy Start. I've also been working with Public Health and Leeds University in their project around nutrition and wellbeing, and hopefully a questionnaire will be going out to all school children this month, and a trial of breakfast clubs. We're also working with Public Health to put in the second stage application of the Shaping Places for Healthier Lives project, and this will be focusing on food poverty in South Shropshire. So I want to thank you for inviting me to present. I think that it's clear that times ahead are going to be challenging, and I think more people are going to find themselves in hardship, which will affect their health and well-being. But I think there are clear actions we can take to support people, and I hope that you'll be able to support our work. Thank you.
Thank you, Emily. It's a very important topic, food poverty, obviously, and I didn't personally know about the Shropshire Larder website, so it's good to know about that. I think, thank you for mentioning Ponsonby. You may not know that is my practice. I suspect all the thanks should go to Helen Tadewell, who's our care coordinator in the practice. I know she's been doing a huge amount of work throughout her time at the practice. Can I now ask if any other members have any comments to make? And I think we've got a few people who are waiting to speak. So I've got Val Cross to start with.
Yeah, thanks, Chair. It's just really to say thanks for that, Emily. Really interesting and thoughtful presentation. And I know we are going to be working together on the round 2 of the Shaping Places for Healthier Lives, which it's got quite a tight time scale at the beginning of October, but if we get round to round 3 we will get a further £20,000 for that, and the 4th stage would be £100,000. so fingers crossed for that, and I know we are working away with that. Thank you.
Thank you, Val. I think we've got Laura Fisher who wants to make a comment, a question.
Yeah, thanks ever so much. Yeah, it's just a comment really. I just want to, as Housing Services Manager at Shropshire Council, I just want to formally thank the food banks and the Food Poverty Alliance for their help during lockdown in regard to supporting us with people that we had to place. We had a significant increase in the number of people coming through, and both the food banks and the Food Poverty Alliance were excellent during that time. So I just want to formally note that. And then also just to comment on the excellent partnership in regard to the hardship forum that Emily did mention, so led by Jackie Jeffrey from CAB. I think we're all aware that there's some really difficult times coming up in housing, looking at evictions and the number of people that we've had to accommodate during COVID. But I'm confident of the partnership working that we've done so far and that we've got going forward, and our overall intention really to work together to support the most vulnerable. So as Service Manager, I feel very supported by other agencies, so I just wanted to formally note that. Thank you.
Thank you, Laura. That's good to hear. Jackie Jeffrey, next, please.
Yeah, so to kind of carrying on from that on the hardship and the poverty part of the social task force, I think there are a number of recommendations that are going to come out and that we're going to ask people to take on board. And sometimes I think we lose a bit of drive and a strategic direction. So, I mean, over 12 months ago, we came to the Health and Wellbeing Board as a review of austerity and welfare reform, and there were some strategic recommendations that were asked to be taken up on that that have kind of lost their way. So this is a refresh as well. And I think we are going to be going into hard times over the next 6 months. And I think we need to relook at the way we help and support people. There are definitely, like Emily said, a new group of people coming forward who have never been in debt before, who have going to struggle with their housing. There's going to be people with mortgages. I mean, that's coming through loud and clear from the food banks, that people with families with mortgages are really struggling and asking for support for food because they've got to pay their mortgage. And so there's got to be some policy changes and an overlook on how local authority pursue debt. And for one example, and I've been going on about this with the Reform and Austerity Group, was that at the moment the council ask, apart from the very, very vulnerable, very, very sick, that everybody who, regardless of their income, has to pay 20% contribution to their council tax. So that's if you can be on universal credit for the first time ever, on very low income, have high mortgage costs to pay, and you still have to pay £7, £8, £10 towards your council tax. Now, council tax support, there's a lot of money coming to the council for council tax support, but it's only going to those who are already accessing council tax support, those very, very vulnerable. And a change in policy would help support those people that are new to low income, to help them over the winter. But it also help the council, because the council has a responsibility to pursue council tax arrears. But if you change that 20% policy, then the council will have to pursue that. And the cost of pursuing council tax arrears is more expensive than actually the money that you recoup back, but you have a responsibility to do that. So some kind of real imaginative thinking about changing policy will make a big difference to people going forward. So that's kind of some of the recommendations that we're going to be asking for people to look at, and I hope there's a wider thinking that would allow that to happen. And thank you to Laura and Emily for the great work you're doing. It's yeah, brilliant. Thank you very much.
Thank you, Jackie, for those comments. I think I would, obviously I'm a GP and from the CCG, so I probably do need to bring Dean in to just respond to those points you were making. Dean.
Yes, thank you, Julian. Councillor Dean Carroll, Shropshire Council portfolio holder for adult social care, public health and climate change. I think we recognise that people are struggling now more than ever. However, those exempt from the 20% contribution to council tax are the absolute most vulnerable people in our communities. And you're right to say that money has come into Shropshire Council, but our costs in responding to COVID have also been extremely high. We don't have a bottomless pot of money to deal with this, so we have to prioritise where that money goes to. And I think that it's right that we've been prioritising support to the absolute most vulnerable people. I recognise that there may be individual cases where we don't always get it right in very marginal situations, but by and large I think it's appropriate that we are concentrating our resources on the absolute most vulnerable. I'm very grateful for everything that the Shropshire Food Poverty Alliance does and is doing. I'm a great supporter of their work. I think Jackie is also doing a great job in the voluntary and community sector. But I think it's important to recognise that in a perfect world where we had limitless resources, of course we would like to extend that programme, but that is not the reality. So we have to prioritise where we allocate the money that we do have.
If I can just respond back to that, what we've said is sometimes things can be cost neutral if there's a policy change, and that, yeah, absolutely, there isn't a bottomless pit, but there are ways to make the most use of hardship payments and money that comes from government to support that area, and to have an open attitude, I think, is what I'm asking, to look at where cost neutral policy change, because the cost of you pursuing that debt is more than the money that you would be expected in. Just a wide thinking, that's all. But I appreciate there isn't a bottomless pit, but you've got more vulnerable people coming in, and if you're looking at public health, you have to have a wider view than just the most vulnerable, who can be identified by the fact that they're just getting another benefit. So, okay. But anyway, I appreciate that's a different time to have a comment, but thank you. Sorry.
Thank you, Judy. Penny, Penny Basin, and that would you be mindful of the time? I think we've still got 2 agenda items left, and it is 11:45. I know disappearing for a bit when my computer crashed wasn't ideal, but we just be mindful of the time. Penny.
Just very quickly, Chair, thank you. Just wanted to say we're hugely grateful for the partnership working with the Food Poverty Alliance. We are able to financially continue to support that through additional grant funding that's come down from central government regarding hardship and the food banks as well. So the details of that still need to be worked out, but we're very grateful that we can continue to provide that support, I think, which with austerity was sort of grasping at straws in recent years. But of course, this is kind of shining a light on all of these problems, and that grant funding that's coming down is helping us. So yeah, again, just wanted to highlight that we're grateful for the kind of partnership working with the Food Poverty Alliance and all our voluntary sector.
Thank you very much. Emily, is there anything that we feel you need to clarify or come back on?
No, it's just wonderful to hear all those comments, and I think we've got some great partnerships going on, and we are having really wonderful conversations. I hope we'll make good progress.
Okay, thank you very much. Before we move on just to the recommendation, Dave Evans has had to leave the meeting, but Julie Davis is substituting for him, so I can confirm that we're still core because there's two officers from the CCG here. So if there are no more speakers, the recommendation is to note the report on the current situation with food poverty provided through the presentation. Please, could I have a proposer and a seconder for that?
Yeah, I'm happy to propose.
Thank you, Jackie.
And I'm happy to second.
Thank you, Penny. Thank you. So I'll now accept the recommendation to note the report on the current situation with food poverty provided through the presentation, unless there's any further comments in the chat. So we move on to, so we've got two reports left. The agenda item 6 is obviously incredibly important, safeguarding community protection, and we've got Sarah Hollinshead-Bland. If she could introduce herself and present this item, please.
Good morning, everybody. I'm Sarah Hollinshead-Bland, the Statutory Safeguarding Business Partner for Shropshire Council, and I'm pleased to be presenting this report. And the purpose of the presentation is to update the Health and Wellbeing Board on where we are with our new governance structure with our Shropshire Safeguarding Community Partnership. So if I could have the next slide, please. I thought it might be useful just to explain where we were previously. We had 3 distinct partnerships. We had a separate community safety partnership, Shropshire Safeguarding Children Board, and Keeping Adults Safe in Shropshire Board. And through work with all of those partners and partnerships, we have come together in a single governance structure, and then I know there will be a number of people on the call today who are already familiar with this. So if I could have the next slide. This is just to explain what it now looks like. If I can just start with the bottom of the triangle, because we kind of see these networks as really very important foundation to the whole structure of the partnership. So the networks that you see on the bottom there are what would have been the boards previously, but they are absolutely crucial. They're people who make those networks up have their own statutory responsibilities in relation to safeguarding and community safety. You know, it's very, very important. They provide people to contribute and lead all of the groups that you see in this structure. What's in the dark blue boxes next are what we've agreed as our strategic priorities, and I'll explain a little bit later on about how we put that together. And then we've described our system groups, which I suppose, to use different language, we would talk about our business as usual groups. So what we've done is combined our case review group. So when we have to do statutory case reviews for children, adults and domestic homicide reviews, that's coordinated through one single group, and we are in the process of establishing joint learning and development groups and the assurance and performance group as well. Each chair of those groups will be attending the executive group, which is the little green box that you can see, and that top triangle is what I constantly refer to as the top table. So people like Andy, Begley, Karen, the Director of Quality, Nursing and Quality from the CCG attends that group. We've got probation services, the police and the fire services as those statutory partners. And that top table actually take on the statutory functions of the Children's Safeguarding Partnership, the Safeguarding Adult Board and the Community Safety Partnership. So if I could just have the next slide. We met together as a group of partners on the 13th of February earlier this year. And what we did was we spent a day together developing and considering what the priorities would be for our new combined structure. And the way that we did that was we presented lots of information to the people who attended the day. They had to work very hard, they had to listen very hard. We looked at national, regional and local information in relation to adults, children's and community safety activity. We looked at the previous priorities of each of those partnerships and what progress had been made on those priorities. And then we embarked on a long listing and shortlisting process, which is how we came up with the priorities that we identified. So if I could just ask you to go back to the previous slide, I'll just run through them in a little bit more detail. So in those dark blue boxes then, what you can see is our joint priorities, which are exploitation, transitional safeguarding and domestic abuse. We identify those as joint because they run across the whole system. They are relevant for children, they're relevant for adults with care and support needs, but they are also relevant to the safety of the wider community in Shropshire. We then have two specific community safety priorities, which are preventing offending. That group actually includes looking at hate crime and antisocial behaviour, and we also have drug and alcohol use as a community safety priority as well. And then there are two separate priorities, one for adults, which is self-neglect, and one for children, which is neglect. But the process I described earlier is how we came to those core priorities. And what we will do is have those as our priorities in the partnership for the next 3 years. And the reason that we've set it for 3 years is because these are very, very big agendas, not only nationally, but for us in Shropshire. And my concern would be if we had too short a timescale, we wouldn't be able to have enough time to work on making a difference to the people who have the experience of these issues. So if I could just skip forward to the next and the next one. Thank you. So there is a team that I manage who support this new combined governance arrangement. You'll see Ivan's picture there. Many of you will know Ivan. He's now the independent chair for that partnership. He will be the chair of all 3 networks as well. And then you can see there on the left hand side the business units that support the partnership and help the partnership become effective. So we have 2 development officers, Lisa and Emma, we have a training coordinator, Corinne, and we have 3 administrators helping us try and run as smoothly as we possibly can. And we'll go on to the next slide. Thank you. Hopefully there's a next slide. Oh yes, there is. So really the next couple of slides are just to outline some of the things that we've already achieved this year. COVID-19, as I've heard on the call this morning, we know that it's had a massive impact on everybody, and it's also had an impact on our partnership structure to the extent where we haven't been able to fully implement the triangular structure that you've seen. And what we have done, though, is responded to the COVID crisis as a partnership, and what you can see there, I'll just take you through a couple of them so you understand some of the work that's been going on. We've produced a podcast, which is a joint safeguarding briefing about adults and children's safeguarding. Originally it was done for volunteers, but to be honest, it is equally applicable to anybody who works or has contact with people with care and support needs or any needs in the health and social care system. We've established a COVID partnership meeting, and what that's been very important to do is establish what we consider to be our essential safeguarding and community safety activity, even during the COVID crisis. Obviously, organisations have made very significant staffing changes, use their staff very differently. But when we're talking about keeping people safe from harm because of abuse or crime, there still needs often to be that face-to-face contact across the whole system with people experiencing abuse. So we've established some baseline expectations of our partners, and we monitor that through fortnightly meetings with our partnership group. And then the thing that supports that is our data collection. So we have a data collection set that matches our essential safeguarding and community safety activity plan. And that's been helpful to us to look at things like domestic abuse, to see what's happening in Shropshire, to look at what's happening in terms of the impact on children, and in terms of adults with care and support needs in a range of other areas. We launched our domestic abuse COVID poster as well, and still marked World Elder Abuse Awareness Day across the partnership, and you can see some of the photos there of people taking part wearing purple for that day to raise awareness about abuse. And I'll have the next slide then, please. So it is very much a whistle-stop tour of how we've changed the structure, but I think I just wanted to kind of invite questions, but also just kind of pose a couple of questions to the Health and Wellbeing Board. How can we work more closely together as partnerships? What is it that you would be looking for from the Shropshire Safeguarding and Community Partnership? How do you want that to look? When do you want it? And obviously any questions that you might have. I know many people on the call are very familiar with this, so my apologies for going over the things you've already heard.
That's all right. Thank you very much, Sarah. If I can now ask members of the committee for their comments again, please indicate on the chat function if you want to speak, and then please unmute, state your name, and then remute on completion. I mean, once again, that was a very whistle-stop but a very informative presentation. Certainly, I think from the CCG's point of view, it would be good probably for our board to hear a bit more directly from yourselves at some point, perhaps in a development session. So I will ask someone to get in touch with you. But
more than happy to do that, Chair.
But thank you very much. So I'm not getting any comments in the chat bar for further questions. I have made a note here to watch your podcast for some of my own personal development as well. So
okay, that's good.
I will be doing that. So unless there's any other points you would like to clarify, then well, if I can ask you that, if there's anything you want to clarify before we move to accept the report. No, that's good. So if there's no more speakers, the recommendation is to note the safeguarding and community protection report provided through the presentation. And if I could have a proposer and a seconder.
Happy to propose, Chair. Rachel.
Happy to second.
Thank you, Dean. Thank you. So I'll now accept the recommendation to note the safeguarding community protection report provided in the presentation, unless anyone else indicates otherwise. Anything in the chat, which I'm not seeing. So if we can then move on to agenda item 7, which is the immunisation and health screening update, and if I could ask Rachel Robinson to introduce herself and present the item, please.
Thank you very much. So it's Rachel Robinson, I'm Director of Public Health in Shropshire. I'm going to keep this presentation relatively brief. This is part of a report that we bring annually through to the board. This time last year, obviously the presentation was very different and contained an awful lot of data, but today I'm proposing just to give you an update on where we are in terms of immunisation and screening programmes, and particularly in terms of restoration. I won't go into huge amounts of detail, but just to remind colleagues that it's Public Health England who are the lead coordinator and commissioner, and our role as a council, and particularly my role to bring to the Health and Wellbeing Board is assurance about where we are with these services. So if I go on to the first slide, if that's okay. Yeah, so the first slide just reminds us of obviously the importance of public health interventions, but particularly vaccines and immunisation programmes, and the reminder of obviously the impact of these and the lives that they've saved. And obviously vaccines particularly important at the moment through COVID. So if I can just move on to the next slide. So yes, just in terms of the screening and immunisation programme, just to update colleagues that obviously during the pandemic in March, some of the programmes were paused as a result of COVID. However, so that being particularly the main screening programmes, the bowel, the breast, cervical, the AAA, so the abdominal aortic aneurysm screening programme, the diabetic eye screening, and the adult immunisation programme. They were paused in March temporarily, but antenatal and newborn screening continued for the most part, and childhood immunisation programmes for the most part continued. But I'll come back to those. Next slide, please. So just to update colleagues, and I think it comes back to the presentation and the findings of the report that Lynn mentioned earlier, we know that where services were suspended initially and are being restored, that information isn't always getting through to the public. So one of the things that we want to do is just to bring to everyone's attention where we are. The restoration of the screening programmes, so the screening programmes that are listed here: bowel cancer screening, the breast screening, cervical screening, the AAA screening, so that's the abdominal aortic aneurysm screening programme, and diabetic eye screening programmes have been, and through June and July, plans have been put in place and approval to restore those programmes. As you would expect, those programmes will start with those where appointments had to be rescheduled, and people are prioritised already in the systems for routine surveillance before moving on to the invitations, for new invitations to these programmes. But those are in place, and we are being assured that there will obviously, which I'll come on to, be current challenges to the programmes and being delivered, but those are being restored and services are working through restoration plans. I think so. If I move on to the next slide, just to highlight some of those, so the challenges, I think. So as I said, there's been a comprehensive set of restoration plans that have been agreed with the providers through Public Health England and through colleagues locally. There's ongoing work in between those. Each programme will have its own set of challenges. I think one of the biggest challenges, as I'm sure colleagues will appreciate, is the restrictions around social distancing, implementation of PPE. So if you think about, for example, the cervical screening programmes, appointments that would have lasted 20 minutes are now 40 minutes just because of the time it takes to don and doff, and other measures that need to be put in place. Workforce has obviously been reduced because some staff have to shield, other staff have been redeployed, and that has obviously been worked through. And then capacity further in other pathways, as surgical time becomes important. So all of that has to be worked through, and it is a challenge, but that is being worked through with the relevant organisations. I think one of the important things, as we always highlight with screening, is around inequalities, and COVID has highlighted that even more. So we are working through with the providers, Public Health England are working through the providers to make sure that we address potential inequalities, make sure we target those groups who possibly could be the most vulnerable, to make sure that we address those in our prioritisation programme as these services are returned and restored, albeit working in a slightly different way to meet the government guidelines. So if I can have the next slide, please. Yes, so just to update on immunisation, there was a survey done across the whole of the West Midlands with practices around the child and immunisation programmes. Those continued, but actually the rates did fall off as patients didn't necessarily want to attend for some of their appointments, and I know Julian will probably be very aware of some of this, but generally with some reassurance, the rates have not fallen below. They have dropped, but not as significantly as you expect. So in some areas they've been reporting 12% drops, and I'll be able to bring more updated figures to a future meeting. But I think to provide some reassurance that despite that obviously whilst these continue to be offered because of concerns about COVID, there was a drop off, but that has been for the most part, people are trying to address some of that and is returning. And obviously the school age immunisation programme, again, delivery stopped. Schools obviously weren't running in the way that they had been, and through lockdown and then into June and July, but that service has started to be returned as well. Obviously, again, issues around the workforce that are being worked through as staff are redeployed. The other final thing to mention is obviously flu. We're now into flu campaign and flu season. Flu vaccination programme, as you'll be aware, has started, and it's never more important than it's been, and it would be right for me to just highlight that at this time. Obviously, we know that those who are vulnerable to flu are also vulnerable to COVID, so it makes that programme just absolutely important. So to make sure that we protect those, the programme has been extended. So if I just move on to the next slide, you can see that we've got increased targets this year for flu, and obviously messages going out to remind people again about their flu vaccine and to make sure that we do get good uptake. Again, it would be remiss of me not to mention that it has posed a significant challenge to practices, to other partners who are trying to deliver this programme, just because of that we need to deliver this in a different way, and because of the time and I know a huge amount of work has gone into that, and in some areas the local authority has been working with colleagues to make sure that we can support in terms of extra provision of space, etc. So again, good partnership working, but we're not to underestimate the work that's gone into address and to deliver some of these programmes. But key message that as we come into flu season, that people do get their flu vaccines. If I can go into the final slide, I think it is. And this just highlights that this year, because of the impact and particularly because of COVID and the importance of people getting their flu vaccines, it has been extended, and people will be aware that it's been extended, for example, to household contacts of those who are on the shielded list. Year 7's been introduced this year. And I won't go through the whole list, but just to explain that has been extended. And also in November and December, the hope is that the programme will be extended to the 50 to 64-year-olds, but that will be subject to the supply of vaccine. And I think that is possibly my final slide. Have I got one more slide? Okay, so just on the final slide is just to remind people that there's obviously lots of communications that will be going out, both nationally and working through locally, to highlight uptake. We can bring additional information, and obviously would ask members of the board to help us cascade that information. We do have a joint comms team working on this, and I think, if it's okay, Chair, I'll leave it there and see if there's any questions.
Thank you very much, Rachel. That was a lot of information in a very short period of time, but very helpful and very informative. So if I could ask members of the committee for their comments, again, please indicate in the chat function if you wish to speak, and introduce yourself and remute yourself when you're finished. Certainly, I'd say as a GP, we're sending out our letters and our invites and scheduling our clinics. I know across the county, practices and PCNs are doing the flu vaccination in a different way, but are gearing up to get started on the immunisations, which are, as you say, more important this year. They're always important, but they are more important. We need to try and hit a bigger group of people and a higher percentage within those groups. So it's very important to flag that. So I'm not getting any questions or in the comments bar. So is there anything you wish to clarify or anything before we move to accept the report?
No, nothing from me. I mean, obviously, this isn't, as I said at the start, apologies, because it's not the level of data that we would usually provide and bring. So I'm quite happy to bring that back at a future meeting, just to make sure that everybody's assured and kept up to date. So I can do that separately if that would be helpful. I think that would be. I mean, this is clearly down as an update, and I think as an immediate update it's good. But when at an appropriate time in the data cycle and the workload cycle, that would be. I'm sure Lee would also welcome that as well. So thank you. If there's no more speakers, the recommendation is to note the immunisation health and screening update report provided through the presentation. So, and as I say, and to allow then for a further update to come back at a point in the business cycle later on. If I could have a proposer and a seconder.
Happy to propose it, Julian.
Thank you, Julie.
Yep, happy to second.
Thank you, Dean. So if we now accept the recommendation to note the immunisations health screening update report provided, and to come back with a further, more detailed report later on when appropriate, unless anyone else indicates throughout the chat, then we'll accept that recommendation. Thank you very much. In terms of Chairman's updates, there are no updates to report today. We've had no notification, there's no any other business. If there is, however, any feedback or questions concerning this virtual meeting, or there were any specific difficulties, please can you pass those on to the committee services, who will collate them and liaise with the relevant officers as appropriate. And thank you to everyone who has not only contributed but has put up with my technical challenges today. And I will now formally close the meeting.
Thank you, Chair. Thanks.
Thank you.
Thanks,